Uh, Good morning, everybody. We are starting the second session of the day, the macular hole and eye. I will be moderating the session of the elite presenters, talking about everything you want to know about ILM, dyes, new techniques, innovating techniques that we'll be seeing coming as we move on. So the macular hole and ILM peeling, since the age of, I think, the man of the cave, and way before my birth and everybody's birth, the ILM was interesting for Didier and Yves Ducournau. And I think nobody would deny their major contribution in understanding what's the role of the ILM in our day-to-day activity and our surgery, in our understanding of many things regarding macular pathology. So I'd like to ask Didier about the ILM peeling. Is it the proper word? And can you explain exactly what we are doing while removing the ILM in our daily practice?
Yeah, thank you, Ihab. I think that your first question is a very good one, and that the employed terminology is responsible for a great part of the lack of understanding in vitreoretinal pathology. A periretinal membrane is not an epiperitinal membrane, and we do not want to remove the ILM, we want to remove the Muller cell hand feet. You should agree with that if you were yesterday at the Claude Baucher expert presentation. She did a tremendous work on this subject. Let's see what happened. The starting point of the pathology is a retinal disease, most of the time an ischemia. The ischemia induces the appropriate retinal response, the astrocytic proliferation, which occur where the astrocytes are located. This is to say, the retinal surface. And you can see here the astrocytes filled with microfibrils of GFAP. When the posterior hyaloid is attached, the astrocytic proliferation enters into the hyaloid fibers so that the PVD leaves a plaque of hyaloid responsible for reflection and metamorphopsia. This is why it is falsely called epiperitinal membrane. This is not a membrane. The GFAP fills the astrocytes, protect the inner layers from the edema, but does not protect the outer layers where the astrocytes are present. So we want the other glial cells, the Muller cells, which are present in the whole thickness of the retina from the ILM to the ELM, to be filled with the same GFAP. And for that, we must use the specific Muller cell stimulator, the trauma. When we create a trauma in the Muller cell, we create an EGFR stimulation which controls the VEGF, but also induces a lot of beneficial properties, and most of all, the repairing process, the Muller cell radial glia. So we don't want to remove the ILM, which is a stupid collagen 4 structure of 1 microns, less than 1 microns. Removing the ILM alone would not induce any sufficient trauma, would not induce Muller cell response. We want to remove the Muller cell and feet, and the ILM works because when we remove the Muller cell, the ILM, we also and always remove these Muller cell hand feet. Of course, we remove in the same time the astrocytes, which are good cells, but we don't care, as we will induce by removing the Muller cell hand feet a much stronger repairing process in the whole thickness of the retina, the transretinal gliosis. This is a concept.
Thank you very much for elaborating the pathoanatomy and the related removal effect of the ILM. Now we're moving to the dyes, the dye and ILM removal. So many of us use different kinds of dye, and in this upcoming presentation, we'll try to touch up on many of the used dyes. We'll start the talking by the Jerzy Nawrocki, the advantages of membrane blue and membrane blue dual. Jerzy.
Thank you. Do we have voice? Okay, okay. I would like to convince you once again that we really do not need a specific staining. And trypan blue, or in form of membrane blue dual, is one of the best stainings we have now. The posterior hyaloid, epiretinal membrane, and ILM are thin, transparent, sometimes difficult to visualize, but surgeon needs to have a confirmation if tissue removal is complete. But as you already know, probably all of you doing this surgery, tissue appearance is different and known by retina surgeon very, very fast. For posterior hyaloid, probably triamcinolone is most frequently used, but we have difficulties to remove it completely. We may have some risk of glaucoma. And please have a look on those videos. Oh, what's going on? Is no video? Ah, okay. You don't see a lot in this video first, but if you inject membrane blue dual, you clearly see the structure of the posterior vitreous and posterior hyaloid, and it is very easy to remove in that way. Another video shows you another situation, how it will, no. How it is.
Do you need to click on it?
Could you move this video?
Click only once.
No.
Go back.
Go back. This is first video. Second. Yes, but I want this video to work. This is working. I already presented it, and this is not working. I don't know why.
Wait, let me try from here. It's not working, Jerzy.
Because it was sent in PowerPoint, probably.
Maybe.
Yeah.
I'm sorry, but if we, so for sure you have good appearance of vitreous in these cases. For epiretinal membrane, trypan blue is the dye of choice, and there's no question about that. So I would like to present you. All those videos do not work. Could you make Didier that? Okay, it's working. Now, who moved it?
Okay, you're the maestro. So
No.
just one more time. Press one more time. Just give it time, Jerzy.
It is not, yes.
Okay.
Fine.
Yes.
Okay. Great.
And for epiretinal membrane, there is no doubt that trypan blue staining is a perfect staining. As you see here, removal of epiretinal membrane and ILM in one complex. Probably the most discussion is about internal limiting membrane. And ICG is probably the most frequently used, but I would like to convince you to use this staining in different indications. This is a diabetic case. And you will see once again the vitreous and the ILM. Here you see macular edema due to traction and staining of the traction, staining of the posterior hyaloid is beautifully seen. And if you compare that to the reality. In reality, our eye and view by our eye is much better as compared to even the best camera. This is not the best camera, is quite normal camera. And so if we remove posterior hyaloid, which is clearly seen and causing this huge edema in the center, it also stains a little bit vitreous in the periphery, but not as good as the former membrane blue product did. But if you look on ILM peeling in those diabetic cases is sometimes more difficult as compared to ILM peeling in macular holes, but you still clearly see where is the ILM and how to peel the ILM, and you can confirm that the ILM peeling in this case is complete. Another video shows you high myopic macular hole retinal detachment treated with inverted ILM flap, and here you see the inverted ILM flap covering the macular hole. And the last example is very unusual case. It is a case of morning glory with optic pit. We will discuss this case during the evening session. But what I want to present you, this is retinal detachment, optic pit, morning glory. This case was operated previously in our department. Here you see the margins of previously removed ILM in the center of the fovea, but still on the boundary of ILM peeled and unpeeled area, we can create a flap once again. So in conclusion, I would like to state that trypan blue, by staining the vitreous, epiretinal membranes, and the ILM, is a useful and not toxic agent to improve the quality of vitreous surgery, and we do not need any specific staining in these cases, but we advise to use double or even triple the dye if it is needed, and to confirm that your surgery is complete. Thank you very much for your attention.
Thank you, Josie. So we have so many blues. You know, the vitrectomy dyes come in different concentrations, different combinations themselves. Dr. Ahmed Salam will present about the blues he knows about.
Thank you. From the blue dyes, I think the best now available is the Blue Dual from Dork, which is 0.15% trypan blue, which is the membrane blue, but they also added brilliant blue and polyethylene glycol, which is the carrier, to help it settle down. And I think this is a great dye because it provides a good spectrum of tissue staining, which you need for membrane peeling, and most of the things you do for the retina, stains the vitreous. It also stains the epiretinal membrane blue, epiretinal membrane, and the ILM. So talking about efficacy, there are several studies and showing satisfactions of surgeon. This is a study I picked up, is a multi-center study where they looked at surgeon satisfaction with both membrane blue and dual. And I'll focus on the dual. The surgeons were mainly from Europe, Africa, and Asia. And they did like a scoring system from 1 to 10. And if you can see here, the mean staining per the surgeon satisfaction was about 8 out of 10, and the ease of membrane peeling was about 7, and less than half the cases, they needed to stain again. And that's regarding the ILM peel. Safety was mentioned on yesterday in more details, but there are several papers showing that toxicity from membrane blue is actually, and trypan blue as well is, and brilliant blue is minimal clinically and on the histopathological level in both experimental and cultured retina cells as compared to ICG. Also the issue with ICG is a concentration-dependent toxicity, as well as it can be affected by your illumination intensity in the eye and the duration of the surgery. Here it's a case where we're using it to stain the vitreous, and it's very good if you're training a fellow, and it stains the vitreous fantastic. And if you've got it because you're going to peel the eye lamp, you might actually well use it, particularly if you're teaching someone. And after staining the hyaloid, you can see the gel and the remnant of the gel. It's also fantastic staining for ILM. I find it better than trypan blue only in my hand. So when I use trypan blue 0.15%, it just does not stain the ILM as well as the dual in my hands. But I've seen fantastic videos yesterday from Jersey and others, and I'm not really sure why I'm getting this. It stains the ERM very well as well. Maybe not as good as the membrane blue only, but it stains well. And what I do is I stain the ERM, and then if I remove it and I go back and I stain the ILM. It also works well if you're peeling under heavy liquid. And what I do is I stain first and then put the heavy liquid. And you get more or less good definition under the heavy liquid, although, of course, as you all know, it can be tricky, and the tissue has a different feeling when you peel. It more like rolls on itself, but you still have very good definition for peeling under heavy liquid. So in conclusion, I would like to say that I think that the dual dye, or the combination of trypan blue and membrane blue, is the best dye for chrome vitrectomy. Unfortunately, it's not FDA approved, so it's not available in the USA. And I think that may be why there's more use of ICG there. Membrane blue, 0.15%, is available in the USA. But as I say, the problem is it does not stain as good in my hands. There are cost implications if you look at the cost of dual compared to using off-label ICG and diluting the whole vial. Actually, it's more cost-effective to use ICG. And I think, but again, that's my thinking, there might be more uptake of ICG in Europe in the future only because of cost implications, that the dual is more expensive. Thank you.
Thank you, Ahmed. So Ahmed explained the use of the dual blue, why is it his preferred method, and also the toxicity implicated. So we have different concentrations of brilliant blues. Dr. Claudia Martinez will explain the stain effect of those.
There's different stains. Since 2000, the ICG has become, but 1 year later, we find a lot of toxic effects. So that's why even it's a very, very nice dye, we stop a little bit of using the ICG. Trypan blue, as Jersey showed, is a beautiful stain in his hands, not in my hands. I have been using, and the ILM is not staining as well as the brilliant blue. In 2008, the brilliant blue came and looks like it's a very, very nice alternative, but in different concentration has different impacts, as you will see. The importance in the different concentrations, it's very important because the ILM sometimes it's very difficult to see, even if you have a lower concentration, you need to wait a lot and will not see very well when you are peeling it. I will show you in this first video the brilliant blue with high concentration. This is I'm from Mexico, so when this brilliant blue came out in, I remember, American Academy, in Mexico, all the retina surgeons went and buy a lot of bottles because the view was beautiful. As you can see, perfect where you are peeling. This is off-label. And I will show you different videos where now this is membrane blue dual, and you will not see as nice the ILM membrane, the peeling. So in these videos, you will see the difference when you are peeling. Sometimes you see, but in some cases, it's very difficult when it's edema or when it's the myopic cases. It's sometimes very, very difficult to see it. So here's the border. Yes, you can see. And this is the trypan blue with the brilliant blue. In this other case, the first one, it's a brilliant blue that it's in a low concentration. And these are the kinds of diabetics we have in Mexico. We have completely retinal detachment. And I think in these cases, it's very, very important to make a very, very good peeling of the ILM, because you will see a lot of epiretinal membranes later on if you do not peel. What I like to see is where is the borders, because this it's with all the retina shrink, so you need to have a very, very good visualization. So with this brilliant blue, I was very happy, because it's not more available now with this high concentration. I have been find different concentration with not as good effect as I was using to see with this 1%. Here I will show you the other brilliant blue I get in US, that it's 0.025, and for me it was almost impossible to see where is the border. I try first in the superior part, inferior part, and after I change and try to pinch a little bit, and I could not see it. So what I did, I find a retinal membrane in the optic nerve, I remove it, and after I put the brilliant blue, I was used to it, and you will see the difference that stained beautiful the ILM. So I was very, very impressed with the videos I saw of different of the trypan blue, because it looks very, very nice. But as I mentioned, in my hands when I use it, it's not very, they do not stain so good as you can see in this video. So it's very important in cases with retinal detachment, when you have all the retina detached and you have a lot of edema, try to have a very good, where are the borders, because otherwise I think it's much more damage that you pinch a lot of the times of the retina. As they mentioned, you need to put first any stain you are used to it before when you are peeling the ILM, when there is retinal detachment, and after put the heavy liquids for you have a good visualization. Otherwise, if you put the heavy liquids before and after the stain, will not stain as good the ILM. So here I put twice, first the 0.025 and after the other heavy one. In this one, for demonstrate what in my hands are like the 0.025 and after the dual from dark, also you can see the exactly comparison of how you stain in what fashion. This is brilliant blue, but brilliant blue, low concentration, and you don't see the borders, and after I put the dark, and after you can see the three difference, and you can obviously see what's the capability of stain in the ILM. This is dark. I always close the infusion for sink a little any stain I use, and after you will see the last one, and it makes a completely different in the capability to see. You can see the borders there where it was completely peeled, and you can extend if you want to extend in all the macula. So there is a different kind of colorants, and if there is different kind of colorants, it's because we are not in just one. The DDR say ILM, Jersey say trypan blue, dual, so why we cannot see a completely nice view with one when there is different ones is because we don't find exactly one that for all the cases are the same. So this is the dual from dark, and this is the 0.025. You can see here in there's articles that if higher concentration, okay, it's more toxic, But also, when you have lower concentration, you need to wait, and you need to wait maybe minutes for get stain. And also, if you wait, you also have toxic effects. So for me, the best is have a high concentration, but very fast and stain, and you don't lose weight. So ILM peeling is very necessary, and we need an ideal dye, and the ideal dye that has excellent contrast and high biocompatibility. For me, a brilliant blue is a very, very good, but in high concentration, the low concentration is not very good in my hands, and different agents has been under investigation because maybe we don't find the ideal one for all the retina specialists. For me, what will like as a surgeon is a very nice dye where you can see what is the ILM, and the epiretinal membrane when you have retinal detachment with BRP, where all the membranes you need to peel as what we paint in the face without any toxic in the skin. Thank you very much.
Thank you very much, Claudia. Going on with more blues, so we have the Kumasi blue. Dr. Jean-Paul Béraud.
Yes, yeah. I am here. So I will present you my way to use BBG. We use BBG with low concentration. It will start.
I think so.
No, normally I think it doesn't start.
Okay. Good. Now. Yeah.
Yes. So I'm using this technique with a low concentration since 2008. I just use one dye, and this video is on the macular hole just to see, as we have seen previously, that this BBG dye can dye the vitreous, so I use it just after a core vitrectomy to see the interface between vitreous and retina. So I use a second, I just pour 1 or 2 drops, and I just remove it after a few seconds. I'm in active suction, and you clearly see the vitreous separation. So I think it's a good dye also at low concentration to see vitreous separation, just with 1 or 2 drops left in the eye for a few seconds. So you complete the vitrectomy, and then you can peel maybe without third dyeing. Sometimes we put a third dyeing. You can peel the ILM. So it's efficient both to see vitreous. We put 1 more drop. This is and we peel the ILM. Here we use the flap technique to peel it. So here we've used 3 drops just for a few seconds. And the second case is in epiretinal membrane, which is the very typical case. And we see that in approximately 50% patient, the posterior vitreous is not detached, even in epiretinal membrane. So we did the same technique, clearly removed the posterior hyaloid. We complete the vitrectomy and then do the peeling. So we have just one dye, and we are quite pretty with a simple technique at low concentration, even if dyeing of the ILM is not very dark, very efficient, but is still enough to do the job. This is just my way. I don't know if it's shared by everyone, but I'm quite happy with 4,000 of cases. Thank you.
Thank you. Jean-Paul Béraud, have you observed any complications of the technique or the dye?
It's difficult to say because we need to make microperimetry to be sure or to test reading speed, but I don't find evident cases with complication, since I always want to dive for the smallest period, left the small quantity, and for short time.
Okay.